Assalamu alaikum and welcome everyone. Thank you for joining us here on a Saturday evening or morning, wherever you are. We're going to begin this event now, so I hope everyone's ready. So this event is entitled Chronic Disease in Ramadan, Sharing the BIMA Approach, and is aimed for doctors to manage Muslim patients during the upcoming holy month of Ramadan, and inshallah a little bit more than that. So before that, let me introduce myself. My name is, I am Associate Professor Dr. Anissa Abdul Rashid. I'm a family medicine specialist from University Putra, Malaysia. And I'm also Secretary of the Islamic Medical Association, or we call ourselves IMAM for short. I'll be in charge of chairing this session for today. And we're going to show you the itinerary for today, if we can have that up on screen. Just to get everyone acquainted with our itinerary. Okay, so we're going to start. We've already started with a little bit of not really registration, but everybody just settling in. Later, we will have 3 speakers with us, and they will briefly introduce what is the BIMA compendium, and then we'll go into acute cases and also chronic cases. And just as a reminder, at the very end, we're going to have some Q&A sessions. So for the chronic disease cases, we will try and make it as interactive as possible. So you may be joining us live from YouTube, or you may be joining us in Facebook Live. So do put your comments there, and we'll have a team that will try and moderate and try and help you with your comments and your suggestions. Okay, so I think I'll move on to introduction of FEMA and BIMA. Just for everybody to get acquainted with who we are, and me using the short forms of FEMA, BIMA, and IMAM. So FEMA is actually an umbrella of federations, which is the Federation of Islamic Medical Associations. And we have a few, I think about 30 Islamic, or maybe more, Islamic associations under them. So IMAM is one of them, which is us. And today we have 2 of the IMAs collaborating. So the other one is, of course, the British Islamic Medical Association. So they will be collaborating with us today and sharing their experiences, and we're excited about that. But I know that those who've registered to join us are from worldwide, and we're happy to see people from all parts of the world coming together for this event. Just to introduce more about IMAM, we have a few chapters under us. So we have the youth, very active youth, which are mostly junior doctors and also medical students. And then if you see beside the youth chapter, there is our IMARET, which is Imam Response and Relief Team. We also have others, which is IMACATS for Children and Teens without Teddy Bear Hospital, and also Rumah Solehah, which is a HIV, halfway home for children and women. So talking on IMARET, we are at the moment launching, or not launching, already launched a campaign for the Turkey and Syria emergency appeal earthquake. So this is our current fundraising event. So for those of you who are tuning in, hopefully we can help our brothers and sisters there. And we are collaborating with DWW, which is Doctors Worldwide, and they are on the ground there helping. So please support this campaign. This QR code we will put at the bottom, a QR code on and off during this event. So hopefully we can get some fundraising there as well. Okay, I think we can just move on straight away to our presentation. So the first, to our event. So the first will be, I will pass on, we have 3 speakers today actually. So the first one is Dr. Sama Waka, and he is from the Department of Primary Care and Public Health, Imperial College London. With him also, we have Dr. Ahmad Mahmood, who is a clinical lecturer in neurology, Queen Elizabeth University Hospital, Glasgow, and also Dr. Nazim Ahmed Guri, who is Honorary Clinical Associate Professor, Consultant in GIM, Diabetes and Endocrinology, University of Glasgow. So we have them 3 here. I will be presenting and sharing this experience. So welcome, gentlemen.
Assalamualaikum.
Okay, so without further ado, I'm going to pass the screen on to Dr. Salman to begin.
Thank you very much. Assalamu alaikum, everyone. Thank you for inviting us, and thank you for the opportunity to present our work to you. We're just going to be presenting to you our work, which we have put together into a volume of evidence called the BIMA, British Islamic Medical Association Ramadan Compendium. And what we're going to be doing today is just talking through how to navigate that as health professionals and how you're going to manage your patients who have got a chronic condition. And we're not just going to be talking about diabetes, which is, of course, a common condition for many Muslims across the world, but there are, of course, many other conditions that also affect our populations. Now, as you will know that if you look on PubMed or if you search Google Scholar for Ramadan and any condition, there isn't that much research out there about Ramadan. There is a little bit, actually quite a bit on diabetes, but many other studies, they have limited use and the quality isn't particularly great. And so what we have tried to do here, in a way catalyzed by the COVID pandemic, is to put together the views of experts, people who look after patients who fast Ramadan and have chronic conditions regularly and are comfortable and confident at doing that, putting their views together with a consensus alongside reviewing the literature, especially where there wasn't much there to begin with or if it was inconclusive. And we put together this guidance to allow you as health professionals to have that conversation with your patients. And it's important to recognize that the guidance that we're putting together here is not an authority. Because the evidence is quite poor, because we haven't got that complexity, we can't give 100% surety or close to 100% surety as you can with other conditions and other guidance. But essentially what we're trying to do here is to provide an informative, patient-centered, individual conversation, because the decision as to whether the person should fast or not ultimately sits with the patient themselves. But it's helpful to know that the work that we have put together here has been published in credible, leading, peer-reviewed medical journals, and alhamdulillah, many more manuscripts from the compendium are also on their way. What we're going to be talking about are theoretical case studies, but they will hopefully help you understand each section and how you can use that section with your patients. And as we should also point out, the religious aspect here isn't something that we're going to be going into too much detail. And we respect those religious differences of opinion where they exist, and as I'm sure all us do as clinicians as well. And of course, it goes without saying that the views expressed here are not those of BIMA, and of course, they don't substitute your professional advice for what you give to your patients. You can access this guide, and it may be helpful for you to do this while we're talking by going to the BIMA website and finding the Ramadan Compendium, or if you just Google BIMA Ramadan Compendium, it should come up. And we have also published a paper in the British Medical Journal, an education piece actually, which goes through that compendium and methods and techniques that you can use to consult with patients as well. And the reference for that is on the screen. Again, this is not a directive. It's something for you to use as an informed conversation with your patients. And you can also take a picture of that QR code as well, which will take you there. This is what it looks like when you do open it up. It is a work in progress, alhamdulillah, every year, or we sort of go through it and update it with more evidence. The initial document, as I mentioned, was produced in COVID, mainly on the basis of rapid reviews to try and get evidence out there. And what we have done over the years is systematically do those reviews and publish them, as I mentioned. So the cardiovascular disease section, for example, the renal disease section, the transplant section, these have initially started as a rapid review and have now become systematic and more comprehensive, and as I mentioned, published in the peer-reviewed literature. So there are many sections to go through, including occupational health, which we have also published, which can be very helpful for conversations with employers around patients who are fasting Ramadan and their work. The compendium has a risk summary recommendation table to it. And don't worry about the detail. We're going to be going through all of this in a lot of depth through the case studies that we discuss. And what we do is that we provide a easy to digest table for you to make a decision with the patient in front of you. And we risk stratify patients into 3 different categories. And depending on where those categories are, that tells you what advice you give to those patients. So some general principles, and I reiterate, don't worry if you're not going to absorb this all in this slide. We're going to be going through it repeatedly in the case studies. But the general principles of approaching any patient apply, which is to get a full medical history. And certainly in Ramadan, a drug history is of incredible importance. We need to explore what is the person's previous experience of fasting. And that is a very important tool for us. Noting that, of course, Ramadan changes throughout the year, but what they did last year will be very helpful for us to determine what we're going to do this year. And try and understand the person's lifestyle and their routine leading into Ramadan. What is their work? What other commitments do they have? Their families, and so on. And then use the Ramadan resources that we've got here to risk stratify the patient. That's the key aspect here. And if the risk stratification decision is that this person is moderate to low risk, we can have a look at the medications and adjust them if we need to. But generally, these patients are okay to fast. If the person is in the high risk category, the medical advice is that they should not fast. We can tell people that they can speak to their religious scholars if they feel that's necessary and look at alternatives. And we'll talk about that again later too. If the person is advised not to fast, that's your medical clinical decision, and they choose to do so, it is our duty to make the patient aware that they're doing that against medical advice, but we should also be trying to look to support them where it's safe and practical, making them aware of red flags, when to terminate the fast, looking for sick day rules, for example, and where it's practical also to support them with monitoring and follow-up. And it's really important that we document these consultations for our own medical legal protection. And this is just a flow chart of how you're going to approach a patient. And we're going to go through this again in all these case studies. But again, the principle of approaching the patient is ask the patient, do you intend to fast this Ramadan? Because if they say, no, doctor, I don't, that might make your decision a lot easier. But if the person says yes, they do, or they're not quite sure, then as I mentioned before, we risk stratify the patient depending on their conditions. And as I mentioned, the evidence that we have for Ramadan is still very new and it's still evolving. So we haven't got that complexity. So we haven't got a paper that looks at a person with epilepsy and heart disease and whether or not they can fast. So we have to look at people who have comorbidities in a slightly different way. Similarly, for frailty, we have to look at that in a slightly different way as well, how old they are. So these will compound risks as well. And so you risk stratify the patient and then you accordingly give them the advice as needed. And sometimes that advice may be to say that I'm sorry that I'm not able to give you any advice because I don't think it's possible for you to fast safely. But in our experience, that is sometimes given too readily, and there haven't been enough exploration around some of the practical things that patients can do to explore a safe Ramadan fast. And just that last box at the bottom, patients should also be aware that COVID-19 can change things. We're learning so many different things about COVID, in particular long COVID, as we get more and more research over the years since COVID first came into the picture. We still advise that we take caution with COVID if people do suffer from COVID or have suffered from COVID and are experiencing long COVID symptoms. I'm going to hand over to my colleague, Dr. Nazim, who's going to go through some of the cases.
Assalamu alaikum. Thank you, Salman, for the introduction and the background to the compendium and also how to approach the use of the compendium, also when it comes to understanding your patient as well. So as mentioned, we're going to go through around 3 cases that are either based on real life or derived from real life or have created realistic cases so that it helps give you a real feel for things. We don't want to make things too easy or equally too complicated, but striking a medium between some moderate complexity so it helps you think, as Brother Salman mentioned, about compounding factors which may increase or reduce risk. And the compendium that we're going to is not going to dictate the decision, but facilitate the consultation process. And we keep making this point because what we do find a lot of the time is that when we do come across guidelines, we always make them, pardon my blasphemy, gospel when it comes to giving advice. What we're trying to say is that we think this is the best decision, but there'll be other factors at play, and also it's the individual's choice. An important thing is for yourselves and ourselves as healthcare practitioners is to be empathetic and thorough, as well as pragmatic when consulting with patients. So as Brother Salman mentioned, we need to really get into the nitty-gritty of their details where we can, but also being pragmatic in terms of what are the priorities, what are the deal breakers, what are the things that actually are not that important when it comes to the factors that are at play. We should not be hesitant to share our concerns when we're making if patients are making unsafe decisions. So if it's
Sorry,
very
Dr.
clear.
Naseem, for interrupting. Could you just press hide at the bottom of the screen there? Can you see your screen at the bottom? It's just blocking some words. Yeah.
There, is that better?
That's better. Thank you.
Okay. So the important thing, as I said, is that sometimes a patient, and it is their choice, at the end of the day, both from a Sharia and also from a medical legal perspective, to do what they wish with their health. But we should not be hesitant in sharing our concerns and documenting our concerns as well, because this, at the end of the day, is a reference point. And we also work in a system a lot of the time where we may not be the only healthcare practitioner involved with a patient or an individual's management or decision-making process. So that's why it's important that if you're part of a team, that other people also in the team are aware of things, and that's easiest and most readily accessed through reading a previous documentation. And as Brother Salman mentioned as well, safety and sick day rule advice given in all positive cases, decisions to fast. So when someone has chosen to fast, even if they are perhaps low or moderate risk, we should still give them safety or sick day rule advice, just so that they're thinking about things and don't overlook things that may potentially lead to harm, or that might lead to a termination of the fast unnecessarily. But obviously, if somebody is going against healthcare practitioners' advice on not fasting, they choose to fast, the sick day rule and safety advice becomes even more important. So the first case involves a 57-year-old male patient attending primary care 1 month before Ramadan starting, requesting advice on fasting. So the past medical history is hypertension and type 2 diabetes mellitus, and the drug history includes amlodipine, indapamide, and metformin. The blood pressure today at consultation is 127/80, and it has consistently been under 130/80 in the past few months. So we are dealing with a well-controlled patient on antihypertensives for their blood pressure. They have a stable HbA1c at 51 millimoles per mole, and patient has fasted last Ramadan with no issues. So the question would be, how would you manage this patient, and what would you advise in this circumstance?
Sorry, Dr. Naseem, I have to butt in again. It's the HbA1c is over millimole. We use the percentage here.
Okay, so that in percentage, as you know, would be 6.9% in the old years. Apologies, it is obviously the millimoles per mole is the more updated standardized units, but it would be 6.9% if you were to use the DCCT conversion. So well controlled regardless of whichever guideline or unit that you use. So the important thing with this is you're dealing with two chronic diseases, if you like. One is hypertension and one is type 2 diabetes mellitus. So what we would do is we would go through the Ramadan compendium and risk stratify into the very high, or moderate to low categories. And we'd also factor in the patient's age, any frailty, previous experience of fasting, and to have more than one comorbidity where the risk may be compounded. So they may have diabetes, they also have hypertension. So we should really check both more than one guideline section, or equally, the table may overlap and cover the other conditions. So we should make sure that we don't look for any overlook any comorbidities when checking the table. So we'll start with the cardiovascular section on this occasion, and then we'll look at the diabetes section on this occasion. Now, generally, we make this interactive where we ask individuals to either speak out or type out if they want to share any thoughts in terms of how they approach or anything. So I'll let the sister come in as appropriate if anybody has made any comments or has got any questions along the way. So I'll let the sister just interrupt as appropriate.
Just no comments yet. Probably a little bit lagging because they're on live. But I'm just wondering, somebody just commented that the screens were quite is a little blur. I think it's your connection because I'm looking at my side. It's quite clear. So maybe the sister or the brother that commented, if you could try and get a nicer connection. But apart from that, there's not yet any comments coming in.
No problem. I accept there will be a lag, so I will pause for 10 to 20 seconds. If there's an awkward silence, it's not that I have frozen, it's just I'm giving time to allow, excuse me, I've got a frog in my throat, for any lag. This slide is familiar. This has the risk stratification table. We've got some general advice at the top, again, some concepts and terms that I've made reference to several times already. And that's when they fall into the high or very high risk. And countries, for example, such as the UK, America, Australia, where we live in temperate regions, we have longer fasts in the summer months and we have shorter fasts in the winter months. So where an individual may be high or very high risk because of the duration of the fast, we have the option of making up the fast or fasting in the winter months when the days are shorter, so that they can do the qada of the fast with no potential ill effects to health. And again, when you're high risk and very high risk, and this will vary from healthcare system across the world, it might be easier or not so easy to be followed up by a specialist or primary care contact while fasting. This is something to give consideration to, that if this can be facilitated, then this obviously makes excuse me, it makes fasting safer for the individual, but also gives peace of mind to the patient as well. And another important thing as well, excuse me, is to adjust medication dose, frequency, or timing, depending on whether the medication is once a day, twice a day, and also the duration of the fast. And what has been put in bold as well is that the individual be prepared to break the fast or abstain from fasting in the case of any adverse events taking place. And this is very important. If a patient is willing to do this, then this indicates that there's a degree of insight on the side of the patient. And this is probably the most important thing, actually, when it comes to a positive decision to fast. It puts everybody's mind at rest. So you'll see this immediate section below that is a cardiovascular section. And there's lots of different caveats to the high risk, very high risk, and the low to moderate risk sections. And I've highlighted in red here, stable hypertension comes in the green section there. So if you're looking at the hypertension section alone, we have, they come into the green section. So from the hypertension side, we're good to go from a fasting perspective. Now from the diabetes section, again, we've got the very high and to low to moderate risk. And we can see that from the diabetes treatment that they're in the well-controlled type 2 diabetes with one or more of the following. And we have that there. If we also were to factor in the fact that they have hypertension in and of itself is not a macrovascular complication. It is obviously a risk factor, but it's not a macrovascular complication. So we don't have anything additional from the diabetes side to pick up on. And you'll see at the bottom of the diabetes section again, that because often a lot of diabetes treatments will involve structured education anyway, so we re-emphasize the importance of structured education, the importance of checking blood sugar monitoring where appropriate, for example, on insulin or sulfonylureas, have access to a diabetes team or people who are experienced with the management of patients with diabetes, not just in Ramadan, but out with Ramadan as well. So coming back to the case, we would class this individual as low risk on the ground that there is no reason to stop him fasting if he wishes to do so. So one thing I would say is when you have more than one condition, we don't necessarily say that the conditions are additive when it comes to increasing risk or synergistic. We have to use clinical judgment and say, could these two factors be at play or not? So I know in other, when it comes to other conditions or managing other treatment algorithms, you might say that you have an additive effect if you have more than one condition. We ask you to use clinical judgment to think if there's an additive or a synergistic effect.
We have a comment here from Shahid Munshi. he or she, I'm sorry, I think it's he, a GP from Manchester. During Ramadan, I have advised patients like this to drink fluids during the non-fasting period and reduce dose of medications as BP and blood sugars go down during fasting. So what do you think about that?
So I will touch on that as it goes through. Thanks for raising those points. So obviously what we have to do is optimally time the medication, and suitability of medication should be discussed with the patient. Non-diuretic antihypertensive medications such as calcium channel blockers, which what the patient is on, may be better taken at suhoor. If the patient is more active after iftar, there's a risk of postural hypotension with extra prayers and humidity in the mosque settings after iftar. So use clinical judgment based on their Ramadan activities. Diuretics and loop diuretics may be better taken at iftar than at suhoor, so that avoid disruption of sleep because of increased urination or frequency, and that's especially if the patient is staying up between iftar and suhoor. So in terms of hydration, it all depends on the duration of the fast, their activities that they're doing, the baseline renal function, because I'd say at the end of the day, we are using potential medication to offload fluid. So we shouldn't be overzealous in telling them to drink too much, but to use common sense in terms of what they're drinking. Obviously, the window of being able to consume food and fluid is less than in, say, non-fasting days and when people's normal routines. So what we were trying to say is try and maintain close to their normal fluid intake, but obviously be cognizant of the fact that you have a shorter duration to do it. If you are going for Taraweeh or playing in a warm mosque, you may need a little bit more fluid than normal, but common sense should prevail. And the reason I say that is, as an endocrinologist, there's plenty of times when we fluid restrict an individual to 1 liter to 1.5 liters for several days at a stretch, and there's no real ill effect on the individual. So sometimes we think we need more fluid than we do. As a general rule of thumb, we're probably looking at 1.5 liters of fluid on average for an adult in terms of their fluid requirements, and this will go up or down depending on common sense factors. In terms of reducing the dose of drugs, again, it will depend on what drugs that they're on, and importantly, how much or how little they're eating compared to normal. So, for example, if somebody is taking metformin and is taking 1 gram twice daily, for example, but they're actually intending to have a fairly normal meal at iftar and a fairly normal meal at suhoor, there'd be no reason to reduce the dose of metformin. If, however, they're intending to lose a bit of weight, or they're going to have one big meal and one smaller meal, then it may be appropriate to drop the dose of metformin with the smaller meal. So again, this is why it's important to not just take a full medical history, but also a kind of lifestyle history as well. And as mentioned, we safety net and give advice on when, inform patient when to break the fast or abstain from fasting, develop red flag signs or symptoms such as dehydration, dizziness, or pre-syncope while they're fasting. And also to document fully the discussion at hand. If the patient wishes to discuss with a trusted religious authority, we always leave that option available to them, particularly if, for example, they're advised that they can fast and feel that they shouldn't be, or more commonly, we advise they don't fast and they wish to fast. But the important thing is when they are consulting with a trusted religious authority, that they share the full information and guidance that was given in a medical consultation, because many times the religious authority may not be clinically experienced or trained to appreciate the nuances of reasoning that we are using. And the key point to take home from this case is that patients and medication should be reviewed in a routine appointment prior to Ramadan, i.e. there's nothing else at play. You've got time to put aside to have discussion on the matter. Now, I accept, given that healthcare systems vary throughout the world, also the fact that there may be flare-ups of COVID or other illnesses and general stresses on healthcare systems, this may not be easy, but we're referring to the gold standard in terms of if we were to do things and we had no issue with resource and doing things the best way, having a routine consultation. And usually we say to do that 1 to 3 months before Ramadan starts. Also, the weighing up of the pros and cons of suitable medication for a patient, and also factoring the duration of fast. Be mindful of voluntary fasts and modification of medications too. And the reason I say that is we're approaching the month of Sha'ban, and we know that from the later hadith that we're encouraged to do as many voluntary fasts as we can, particularly in the first half of Sha'ban. So individuals may be doing this. So we should be mindful of this so that we shows that we appreciate the religious sensitivities and actions of individuals in the run-up to Ramadan, but also we could use the trial or the voluntary fasting as an opportunity to test how Ramadan may go for the individual. You can use them as trial fasts, for example. We can make changes in Sha'ban to see how they get on with their voluntary fast, so that when Ramadan comes, we have a bit of experience in terms of what fasting may do to the body and also what the body may do to fasting from those voluntary fasts. And ideally, we would like to have a review after Ramadan to discuss the medicine management moving forward. So Ramadan has passed. How has Ramadan been? Documenting those experiences, so we're ready for next Ramadan. But also, it may also give an indication as to what to do after Ramadan as well. You might not necessarily go back to the original regime or routine. You might. Again, this gives an opportunity to discuss things. One moment, my screen. Here we go. Case 2 is a 60-year-old female who attends primary care 2 weeks prior to Ramadan, and she has an acute illness prior to Ramadan, and she's got diarrhea and vomiting for 3 days. She's got a background of renal disease in the form of CKD stage 3. She's got hypertension as well. She's only taking Ramatril 5 milligrams once daily. Despite her current excuse me. Despite her current symptoms, she still wishes to fast when Ramadan starts. Now, obviously, we have 2 weeks to go. The hope is that acute illnesses like this do resolve themselves, but nonetheless, we are uncertain. And she has got past medical history, and she's 60 years of age. So the question is, how would you manage this patient, and what would you advise? So I accept there'll be a bit of a lag. So I'll just pause on the screen for a few more seconds in case anybody wishes to type their thoughts on the case or how they might manage. So as I said, the symptoms and residual effects may resolve before Ramadan starts, or this may not happen. So what we would say, given her past medical history, and I think regardless of Ramadan or otherwise, is do appropriate monitoring or tests at that consultation. And try and maybe follow up the patient in a week's time for 2 reasons. Again, because of how the consultation goes on this occasion, but also the fact that Ramadan is around the corner. And I accept the 7-day follow-up may not be easy in some healthcare systems. If there's no persisting acute kidney infection, injury, and the patient is well, then we'd go to assessment of chronic disease as we would ordinarily. But if the symptoms have not resolved, then we may have to look at things. Now, sorry, this test result screen should have appeared a bit sooner. These are the test results of the patient from their 2-week review. We can see that the EGFR is 51 millimoles, 51 mils per min, so it's reduced. The creatinine is 200. The sodium is slightly up. The potassium is also up as well. The urea is up. The MSSU was normal, and the urine tests show a bit of protein, and the blood pressure is reasonable. So I have mentioned that the individual does have CKD.
Sorry, Dr. Nazim, can I just ask what is MSSU?
A midstream sample of urine. So,
and the urine test is different from
so
that?
this is a urine dip test.
Oh, and then you have another test? Urine test is protein positive?
Protein. So that's the urine test is the urine dip test, and the protein is what you have on the dipstick from that. So if you were to dip the urine, you have these screening tests. You have 2 pluses of protein on the dipstick. So these are the test results. Sorry.
Okay, that's fine. Yeah, thanks.
So for the individual, the urine test shows there's no growth in the urine, so that's normal. So there's no concomitant urinary tract infection. There's a bit of protein in the urine, but we have mentioned the patient already has CKD3. The EGFR is 51, in keeping with CKD3. The creatinine possibly is a bit high, suggesting maybe they might be having still a bit of an acute effect on things, but the blood pressure is reasonable. So what we would say is at that reassessment, if the symptoms haven't resolved, then we would use standard clinical practice and judgment when it comes to somebody who has an acute kidney injury. and that may involve a referral to a medical or renal team, depending how concerned you are. And we would like to make sure the patient is medically stable before Ramadan is started. But if the symptoms have not resolved, then we would go to the acute section or the management of acute illness in the Ramadan compendium. And this is the figure or flow diagram we have from the acute illness section of the compendium. And what we have done is, because of obviously the effect of COVID in the past 2 or 3 years, have a COVID pathway and a non-COVID pathway. And we'll be going down the non-COVID pathway here. We would basically, and we're using basic principle of fiqh, which is predominantly taken from the Hanafi school. I am aware that many might be following a different school or no school of thought, but it just gives a starting point, particularly for in terms of keeping patients safe as well. And what we would say is that if we feel that the illness is going to worsen through fasting, or the delay is going to be recovered through fasting, then we would advise abstain from fasting until the individual is better. Or we have a substantial concern or fear that if they were to fast with their current clinical circumstance, that they will cause harm to themselves or delay the recovery of their illness. So this is the acute illness pathway that we have in the compendium. So, assuming that the acute illness is not at play or that is recovered, then we would go back to the compendium as we would for chronic disease and risk stratify the patient and in terms of seeing whether they're very high, or moderate to low risk. And again, giving consideration to the patient's age, frailty, previous experience of fasting, and if they have more than one comorbidity where the risk may be compounded. And we would go to, on this occasion, the CKD section, and the patient would come under the high risk category. I haven't brought the table up, but hopefully you have access to the compendium through the scanning of the barcode or Googling for the hyperlink. But they would be classed under high risk, and they would be advised not to fast. And here we go. Actually, I've pulled up. You will see here that it falls into high risk because they have CKD 1 to 3, and their kidney function potentially could be unstable depending how it's resolved. There were initial electrolyte abnormalities, and the patient is on an ACE inhibitor. So again, this is what we are advising based on the risk stratification, but the individual may feel otherwise, and equally the clinician may feel otherwise if they think the acute illness is over it and they generally have good health. But it is a starting point for discussion for the healthcare practitioner with the patient. And obviously, as I mentioned before, if the patient wishes to fast, we would document in the patient's notes, try and follow them up while fasting if we can. And I said this may not be easy. Discuss with their trusted religious authority about the risks of fasting if they're not willing to follow the medical advice. And this is to really make sure the patient is getting that reassurance from the religious perspective that the advice we are giving is not at play or not at odds with or contradicting the advice that's in the Sharia. And inform the patient when to break the fast if they're becoming unwell, if their healthcare deteriorates, i.e. the sick day rules. Case 3, I'll hand over to Dr. Ahmad Mahmood to take through.
Jazakallah khair. There was a couple of questions regarding diabetes and hyperinsulinemia. Nazim, I don't know if you want to take them now or do those at the end.
Yeah, we can do. That's not a problem. We can take them now.
Okay, I think we'll go for the latest one for the team to bring up from Harliana Muhammad Hanif. She has a question in relation to patients with CKD, any stages with comorbidities of hypertension and diabetes on insulin. Is there a recommendation for this particular group of patients? And how about ESRF and stage renal failure patients? And so far, she says, my consultation is patient-to-patient basis, but is there a particular guideline or advice? And she's seen quite a few cases of patients with CKD stage 3 and above whose renal function worsens during Ramadan. So,
So what I would advise is, and you will have seen from, if you've seen the slide from the diabetes slide, but also from the renal slide, we do make reference to different levels of EGFR or stage of chronic kidney disease. There is mention as well in the diabetes section about the comorbidities and use of insulin. So I think my advice would be to go to the diabetes section in the Ramadan compendium, to go to the renal section, and hopefully all your questions will be answered. Both those sections or both from the compendium have been published in peer-reviewed literature, and the references for both these papers are in the respective diabetes and renal sections. The authors are the authors of the chapters themselves, and you should be able to get all your answers and get all the details you require for either diabetes or renal disease, or in fact when you have both. And you'll find that both papers make reference to comorbidities as well, and the advice is consistent. So what you find in the diabetes section will not contradict what's in the renal section when it comes to comorbidities, and vice versa. Anything else?
Yeah, just a reminder, we've put up a link for the BIMA compendium so that everyone who would want to have a look, it's up there on the screen and also in the chat section, so you can have a look there. Okay. There's another question on why from at Peace. Why would you put patients on RAS blockers as high risk for fasting? And is it based on mechanistic understanding or actual study?
So as Brother Salman mentioned, the actual data and evidence we have is not very good, and it's based on mechanistic understanding. And you'll see as well that the potassium was 5.9 for that patient in the acute illness. What that highlights is that when a patient becomes unwell on these medications, they can develop a hyperkalemia. They can potentially develop an AKI. So it's to understand what can happen if somebody is fasting and perhaps not paying attention to their hydration status or to their symptoms during the fast. Again, for more information, they can read the paper on kidney disease and Ramadan, which is published in the Clinical Kidney Journal, which is the journal of the European Renal Association. This was a commissioned piece, so more information will be available in that piece, and that is referenced in the compendium.
Okay, we have a question about hyperinsulinemia. I think this lady was diagnosed with that. She's from Malaysia. She says every hour she needs to take sweet food to replace her sugar because of hypoglycemia. So she's asking if she can or cannot fast.
So when it comes to hyperinsulinemia, are we talking about iatrogenic hyperinsulinemia because they're on insulin injections, in which case the obvious thing is to reduce the insulin dose? Or are we talking about a physiological hyperinsulinemia in response to the insulin-resistant state the individual is in? We have to understand that hypoglycemia, by definition, is when the blood sugar is less than 72 deciliters per 72 grams per deciliter, or if the blood glucose level is less than 4 millimoles per liter. If it is not at those levels or less than that level, it is not hypoglycemia. So this is why it comes back to patient education being key to helping someone fast. They should have, if they have basic education on diabetes, we should understand what hypoglycemia is. Now, if someone is simply insulin resistant, then the hyperinsulinemia in and of itself will not cause hypoglycemia unless it's a reactive hypoglycemia after a meal, in which case you'd give specific dietetic advice on low glycemic index foods, eating smaller meals. And also hyperinsulinemia in terms of hunger is only a symptom. It is not always a reflection of hypoglycemia. So if somebody's feeling hungry, then that could maybe a reflection of the fact that they may be overweight. And if they're overweight, they may have a stomach which is slightly larger than normal. And one of the signals for hunger is when the stomach empties. It sends signals to the brain to fill it up. Now, if somebody is overweight, they usually have a larger stomach. So what happens is the signals will start off earlier. So this is simply a physiological response in relation to the size of the individual's stomach. So hunger in and of itself, it would not be a reason not to fast. In fact, there have been arguments say they should be fasting because it will help dampen the hunger signals. And hyperinsulinemia in and of itself would be a reason not to fast unless it's because they are injecting insulin and they're having hypoglycemia with that, in which case you would go back and follow the diabetes guidance in the section and refer to the paper in terms of what to do with individuals who are on insulin and fasting.
Okay, I think that's all. Thank you very much. We'll leave the rest towards the end. their general questions.
Okay, Brother Ahmad.
Yeah, pass over to Brother Ahmad. Thank you.
We've got the slides up. Okay, Jazakallah khair. So this is case number 3. So we have a 49-year-old male patient being seen in primary care a month before Ramadan begins. Their past medical history is that they have stable angina and they have hyperlipidemia, and their current medications are aspirin, isosoride mononitrate, atorvastatin, lansoprazole, and a GTN spray. So perhaps, inshallah, if people have the compendium access now, you can have a quick look at the relevant sections. I'll give a couple of seconds to do that, and if you can use the chat function to maybe suggest if you would consider this person moderate low risk or high risk or very high risk. Nazim's given away the answer there. Okay, so if we could have the next slide, Nazim. So stable angina would for the purposes of this fall under the moderate low risk category, so then what we're left with is the hyperlipidemia and the medications. And actually here probably the medications are more relevant in looking at to decide, can these be compatible with fasting, and if they can be compatible with fasting, then are they best taken at suhoor or are they best taken at iftar? So if we first of all consider the aspirin, then perhaps that is once a day, so that can continue, but perhaps we best move to iftar time to avoid gastric irritation. Isosoride mononitrate taken in the BD dosing as per our case would be complicated in that that's usually taken sort of breakfast and lunchtime, usually by most patients. So you might consider switching them to a modified release preparation so that they can continue taking that at suhoor time and avoid having to take the daytime afternoon dose. And the statin and lansoprazole, the statin would be taken ordinarily at night time in any case, and lansoprazole can move to iftar or suhoor, whichever the patient prefers. So generally speaking here, low risk for the two mentioned, and as we stated earlier on in when using the compendium, comorbidity can definitely be something to consider, and in fact we would suggest that in some cases, not so much in this case, but in some cases, a number of moderate to low conditions brought together, taking into consideration the patient's age, might prompt you to put someone with an otherwise constellation of moderate to low risk, conditions be considered up into high risk. Or, for example, if for example, in the British summertime when the fasts are particularly long, up to sort of 20 to 21 hours, then something that is low to moderate risk in that instance, perhaps based on that individual's previous experience of fasting, might then have to be considered in the higher risk. So just to go into a bit more detail regarding this patient's cardiac history. So in patients with stable angina, stable coronary artery disease, the limited evidence we have would suggest that they are in a sort of low to moderate risk. However, patients that have recently suffered a myocardial infarction or post-cardiac surgery, particularly within the first 6 weeks, then we would consider them to be in the higher risk category. And some of the guidance that we have from the British Heart Foundation would suggest that these patients would struggle if they were fasting to take part in cardiac rehabilitation, and so that our early 6-week period post myocardial infarction would be a high risk time to consider fasting. Next slide, Nazim. I'll just signpost at this time. I think Salman highlighted this at the very beginning. This practice pointer in the education section of the British Medical Journal, which was published last year, and hopefully that in some ways is a sort of partner to the Ramadan compendium. Lots of practical advice in there, so a few different flow charts, and particularly the infographic can be quite helpful if that as something to refer to, which takes into consideration a lot of the different aspects that might go into a shared decision with the patient. But one of the sort of common questions we have, that what options are there for people that are unable to fast during Ramadan? So the first of those would be to obviously have qada fasts at a later date, and that can take up a number of different sort of strategies. So either patients may know from previous experience that they can fast maybe one day or 2 or 3 consecutive days, but the 29 or 30 consecutive days of fasting are where they run into problems. So many people can employ a strategy of maybe fasting for 2 or 3 days, having a break for 2 or 3 days, and then at the end of Ramadan, the days that they have missed of Ramadan fasting, then make those up as qada fasts later in the year. Or earlier on we mentioned the option for summer-winter switching of fasting. So summer months, either because of high temperatures or because of the longer hours in regions like the UK, then the decision to fast and the risks of fasting are amplified, even when in the same patient taking the same medication with the same past medical history. So you then may have a situation where because of a 20-hour fast for a patient that's on twice daily medications, may find that they just can't do that fast in the summer months unless those medications can safely be altered. And so for that patient, you may suggest that they do their qada fasts in the winter rather than in the summer. And then, of course, we always have to remind people that Ramadan, as much as the core of it is about fasting, that there's a lot else that they can do to still partake in the spirituality of Ramadan. I think one of the interesting aspects that we've had dealing with discussing this with non-Muslim colleagues and stakeholders, I think they often assume that the Muslim patient will be looking for reasons not to fast, and in fact, all of us who have been in those positions advising people know that it's entirely the other way around. So those who are older, those with comorbidities, often they have a very strong feeling that they want to fast, and actually convincing them that perhaps it's not something that they can safely do with their health conditions. So in that case, highlighting to them the extra prayers during Ramadan, the extra recitation of the Quran during Ramadan, all of that is still part of the spirituality of Ramadan. And in fact, the sacrifice from them of not fasting, inshallah, perhaps Allah will reward them for that as well. And lastly, the giving of fidya, we haven't gone into to detail about that here, but the for the person who perpetually knows that they will not have the opportunity to fast because of a chronic condition that isn't expected to recover to such a state where they would be able to fast at any time of year, then the replacement of that with fidya. Next slide, please, Adam. Just quickly, would like to acknowledge, mashallah, a very large team that had input to the Ramadan compendium. Lots of contributors, lots of authors, lots of reviewers as well that came together at the beginning of the COVID-19 pandemic very quickly and with mashallah a lot of effort to put this together, and we can see, alhamdulillah, that those efforts have then over the last couple of years amplified, and now we're able to publish a lot of those findings in leading journals, and also to share what we found in platforms like this. So I think that's all from myself, Brother Nazim and Brother Salman at this point. I think we're going to perhaps move on to some Q&A, and I'll hand back over to Dr. Anisa.
Thank you very much. Alhamdulillah. Very good sharing. There's a few questions and comments that we're gonna, I think, go through that we missed during the earlier sessions. So one of the questions are by Peace again. Are we making it too easy for patients to be in high risk, hence they don't fast?
I'll probably come in there. What I would say is that we are trying to encourage safe fasting, and as we have highlighted from time and time again through the presentation, is this compendium is a starting point for discussion and to facilitate a discussion and review of your patient. And that is why within the one of the flow diagrams Brother Salman spoke about, we factor in previous experience of fasting as well. What you'll find with a lot of guidance that was there before we brought out the compendium is they were far more strict, or they were far more lenient, you could say, towards not fasting. What we have tried to do is shift the goalpost to a more patient-centered, pragmatic approach to safe fasting. And we have to also understand and appreciate that our first medical ethics principle is to do no harm. So it's not that we're making it too easy not to fast, but what we're saying is that we're saying, think about these factors which may put your patient at risk. If you can mitigate these risks in advance of Ramadan through trial fasting and having a consultation beforehand, then we are encouraging that. And that's where some of these papers provide a bit of guidance in terms of how to optimize medication, for example, so that we run into less harm during Ramadan. We also have to understand and appreciate that for many individuals, they can't access a Muslim doctor when it comes to their Ramadan consultation. And you'll find from those experiences, if you speak to patients or colleagues, that they have a very, very low threshold for advising individuals not to fast. So actually what we're trying to do is try and make it a bit more objective in terms of making them think about certain factors, so that if you are going to give a decision not to fast, you're basing on something that's a bit more kind of clinically robust. And just before I hand on, I made a bit of an error with the diabetes units because I'm not an American. It's milligrams per deciliter, not grams per deciliter, when I talked about hypoglycemia and the threshold being less than 72.
Dr. Anita, can I just come in with an additional point? I think it's also worth highlighting, certainly in our British context, and I think the same is probably true for most Muslim countries, Muslim majority countries, as we're all westernizing, is that our populations are becoming more unhealthy. Obesity is rising, diabetes is rising, cardiovascular disease is rising. And this is an inevitable consequence of that for our populations. Is the more unhealthy our communities become, the more difficult their Ramadan is going to become. So actually, I think I would probably flip that question on its head and say that, do we need to be doing more for our patients to make them fast Ramadan safely from a public health point of view? So actually, as my colleagues have said, Ramadan isn't just a problem in terms of whether or not who can or can't fast. It's also an opportunity. People who are smoking in Ramadan, the majority of Islamic legal opinions would say that smoking invalidates the fast. Why don't we do more to promote transdermal, nicotine patch replacement, for example? Weight management, perfect opportunity. For 30 days, you are radically adjusting your routine in terms of what you're eating and drinking. Why are we not thinking about a weight management program during Ramadan? So I think there's more to it than just thinking about, are we being too restrictive here? I think we need to think slightly more holistically and think about our populations at that level as well.
And just to add to that, for example, when it comes to type 1 diabetes, you'll see a lot of guidance generally puts type 1 diabetes at a more moderate, more higher or very high risk of fasting. But there is evidence, there's guidance that's been written by diabetologists, which have actually said that if you meet certain prerequisites, then actually fasting would be pretty safe if the prerequisites are met. And in our compendium, we have touched on this. So for example, if you're to take the IDF DAR guidance, they take they have a lower threshold for advising patients with type 1 diabetes not to fast. However, there is a paper in Lancet Diabetes Endocrinology, which is written by diabetologists, which have said that if certain prerequisites are met or certain things are in place, then actually safe fasting might actually be something that could be tried and encouraged. So for example, if they are on a pump and they have closed loop systems, or if they have flash or continuous glucose monitoring, these things reduce risk. But we also have to understand that not everybody has access to the same resources when it comes to healthcare as well. So that is why sometimes when guidance is written, you have to look at the context and the caveats that are given with it and not just pay attention to the table.
Yeah, thank you very much for the answers. We have a few questions specifically on fasting here. One of it is Murad Omran. He's asking, IV drip or GTN lingual or nasal sprays, does it break fasting?
Brother Ahmad, do you want to come in?
So we have gone into issues like this in the compendium because these can sometimes be issues of where there's differences of opinion, and so we've largely stuck to management of chronic diseases within sort of my experience, then nasal sprays and GTN lingual sprays would break the fast, but IV drips, according to the some opinions, would not break the fast. But of course, the sort of I think whenever someone asks this, I always sort of ask, well, a patient who's requiring an IV drip either for hydration or antibiotics, likely their illness in and of themselves means that they probably shouldn't be fasting. If it was for a different indication, then whether it's nutrition or otherwise, that also has to be taken into consideration. But from a general perspective, an IV drip would not. But why a patient with an IV requiring IV medication or hydration probably shouldn't be fasting. So it's a bit of a sort of one with a bit of caveats, both because of the differences of opinion and the context.
Well, we often get this kind of questions by patients, but I think it's a little bit difficult if we don't know the context. So we're having questions here asking, again, if hyperinsulinemia can continue fasting or not. I think my advice to the person asking is to ask, because we need to evaluate first, as Dr. Nazim earlier said, what are your causes of insulinemia and all that. So it's better to be discussing with your healthcare provider on that. Just on the previous point on safe fasting, the same person commented, can we flip also for certain patients with certain conditions? Is it advisable to fast? So for example, obesity, you need weight loss, and for diabetes, you need sugar reduction. Anyone want to jump in there?
Sorry, can you say the question again?
The question is, can we flip it and make it more for certain condition we advocate for fasting? So for example, obesity, weight loss, you need a weight loss of 3 kilograms and so on and so forth. And for diabetes, it's suitable to fast because they need to reduce the sugar levels.
Yeah, so generally you'll find that in the guidance, and again, these presentations are really to help give you a flavor of how to use the compendium. Is the compendium and the papers associated with it that we've published. We talk about healthy lifestyle and the general health benefits of fasting over and above, the spiritual side, in terms of an opportunity to lose weight, an opportunity to improve sugar control. And in the obesity section, for example, in the diabetes section, we do talk about this as an opportunity for individuals to try and lose weight. Giving specific targets, again, this is where the patient-centered approach should come into play, and you should tailor it for your patient. Obviously, previous Ramadan would be a good indicator. One thing we generally advocate, obviously, with Ramadan, it's not 30 days of fasting and 30 nights of feasting. And simple advice like that just helps actually put general healthy measures in place. And probably from that, you might find that you get the desired effects. But I think if you want to use a target, for example, of losing 3 kilos or 5 kilos, depending on their baseline body weight, then I think that'd be reasonable. I would very much leave that for a clinician to stipulate, and we wouldn't want to be too prescriptive on our side, because if you think about it, we've got thousands and hundreds and thousands of millions of people who are fasting with medical conditions, and if we get too prescriptive at our end, then we run the risk of creating not just a guideline, but almost like some text that people cannot deviate from. So we have to be careful that we don't approach that. And you have to understand as well that when it comes to medical literature and medical advice, people see things slightly differently. For example, myself and Brother Salman were asked to review a pregnancy paper and outcomes, and the way we look at it and from the context, I think is slightly different to perhaps the authors who weren't of a Muslim background or who weren't necessarily of a medical background. So people can sometimes look at the same circumstance but take a different conclusion from it. So that's why we try and keep things a bit loose and leave it at the discretion of the HCP as to how they want to advise their patient.
And may I just also add on this, that Ramadan, of course, the month of Ramadan begins on the sighting of the moon of Ramadan, but your fast of Ramadan doesn't have to start then. And I think, as we've discussed in these cases, if your patients or you yourself have got health conditions, use the time before Ramadan to understand your body, understand your goals, set your goals, prepare for Ramadan. When we come to looking at an exam, when we come to looking at, booking a holiday, we do so much research about that. And I think we need to think of Ramadan similarly if people have got health conditions, to do your research, speak to your health professionals if you need to, try fasting, try a different medication with guidance as you need to. Don't just expect everything to come into place on day one of Ramadan, and especially if you found a change in your condition. And again, we're just going back to everything that we mentioned before. Prior experience is so important for these patients. If you've tried every year for the past 30 years to lose Ramadan, be realistic. Are you going to lose Ramadan this year? Or maybe you need to think about your goals slightly differently. Maybe you need professional help so that you can be targeted in terms of your weight loss, speaking to a dietitian and so on. So again, just to reiterate again and again, look at the compendium. It is a tool that is only useful if people use it. And I know we've mentioned it many times. There's no point us doing these types of talks if people don't go away and look at it in the context of their patient and doing an individualized assessment with them. But that individualized assessment requires preparation and requires an investment. And our hope is that, in the future, we can continue to build on this and add more evidence and continue to give better guidance for people. But ultimately, it's all about the individual decision and the choices that they make, and giving them the informed tools to be able to do that.
I'm just wondering, how would you manage comments? A lot of it is on fiqh. Can you just comment a little bit on that? Because I think we're getting a few questions on that here. It's maybe you can comment on how you use that to address these kind of issues. Like, is this halal? Is this haram? Does this break the fast? Does that not break the fast? How would you approach that? Anyone?
So in relation to the fiqh of it, first and foremost, obviously, we recognize there is a difference of opinion in fiqh, but certain principles are consistent regardless of school or not following a school. And that's why I would say go to the compendium. We have made reference where appropriate to the fiqh aspect. We have got scholars who are part of the authorship of the compendium and also of individual papers. The BMJ paper as well touches on things that, for example, drugs and routes that may invalidate the fast and those that will not. And again, they're also either referenced to other papers or referenced to actual religious texts or resources. Most important thing, as they're all saying, is you need to go back to the compendium, go back to the BMJ paper and read. And from that, hopefully a lot of your questions will be answered either directly from those resources or from the references that we have referenced to that. And obviously we do recognize, for example, with inhalers, etc., there might be a slight difference of opinion. And this is why we've always advised that the patient themselves go and speak to a trusted religious authority if they follow a different opinion or they feel that there is a difference in opinion.
Yeah, what's important is the discussion between, I think, an informed discussion for the patients, because we can only give them information based on what we have. And so far we have the BIMA compendium, so that will help. We have other resources as well. So I think the more patients you see and the more you discuss, of course, we don't have right and wrong every time. And especially if it involves religion and fiqh and different understanding, we do have to understand that people come from different backgrounds. In Malaysia, we tend to stick to one, but I think probably we have to be aware of other understandings as well. So it is like communication with our patients, I guess, in that sense. It is very tricky, I would say, and very challenging.
Yeah, I mean, one thing we would say that there is a paper that I've co-authored on driving and diabetes in Ramadan, because this is an interplay between secular law and fiqh, for example, with hypoglycemia. And in that, we have a bit of a discussion on Sharia, maqasid, and fiqh. So if people want to get have a read from that, then it helps. We discuss a number of principles which come into play when it comes to making decisions. And we have referenced some traditional texts in that. So that is a resource, and that reference is found in the BMJ paper, but also in the compendium as well.
Okay, so we will do something about that. There'll be a link, a QR code for everybody who has attended today, and whoever gives your details, we will be emailing your certificates along with the links to the relevant documents that has been said.
And just for example, if you were to go to the BMJ paper in box 3, for example, and this is relevant, for example, to the third case we discussed, this is the angina case. And obviously, one of the treatments for angina or symptomatic treatments is sublingual GTN. Now, we have commented on this in the BMJ paper, saying, for example, that nasal and buccal may be allowed if there's no risk of passage into the throat and beyond. So again, it's about, when it comes to these fiqh matters, it's about understanding what may invalidate the fast and the reason why. Sometimes by understanding the reasons why, it helps us understand why that thing may invalidate or may not invalidate the fast. So again, this is why it's important you go back to those papers to read more.
Okay, there's a few questions not directly related, but maybe you would want to comment on it based on your experiences as physicians. Is it true that type 2 DM and hypertension can be reversed by keto diet? Keto.
In terms of weight loss, we know that weight loss has significant benefit in individuals with diabetes, particularly those early on in their diabetes journey, and also in those where obesity is the main trigger for things. So yes, safe weight loss will benefit a patient's diabetes. Ramadan may be an opportunity to embrace that that opportunity. But the important thing with keto diets and things, for example, are that you're not harming yourself by being excessive with your diet to the extent, for example, it's affecting your sleep, your concentration levels, and your general well-being. So I think the important thing in these circumstances is to have that appointment with your healthcare practitioner and discuss the embarking of a diet, and also how aggressive to be in the month with that diet. Because remember, the absence of food is only part of the package of Ramadan when it comes to our ibadah. At the end of the day, Ramadan is there not for us to abstain from food or drink, but it's Ramadan is there in order that we may acquire taqwa or piety, and that we may draw near to Allah subhanahu wa ta'ala. And the abstinence of food and drink is one of the more zahir, or the most zahir form of that in the month. So we should not make the means the end, but and understand that if we are going to embark on certain diets, if it makes us very tired, it compromises the fast in general, or being able to do tarawih, etc., we should be sensible about things.
And just to add, Denise, I think just reflecting on some of these questions, I think it maybe speaks to some of the issues in our countries of patients being able to access religious authorities who understand the medical situation. And I think that's something that we can't fix, but we can obviously try having. We have to stay in our lane as clinicians who are Muslim and who understand all these things. But we also can't go into that conversation about whether or not, for you, in your understanding of the Hanafi fiqh, for example, which the default position is inhalers may invalidate the fast, whether for you, the fact that you work in a dusty environment and it's made your COPD worse, and for you, if you did have the inhaler, you could facilitate a safer Ramadan. We can't go into that fiqh territory. What we can do is arm that individual with the tools to be able to say to a scholar that I've spoken to a doctor, to say that if I had the inhaler, I could potentially fast. In my situation, would I be excused from fasting? Or would I be someone who, in my understanding of this halal haram situation, in my school of thought, am I allowed to have an exception? And I think that's maybe what this anxiety is referring to. But just to reiterate what the compendium is there for, it is to provide the medical opinion, the medical perspective, but that perspective is very much informed and aware of some of the anxieties in the religious opinion. So we can help you as much as we can on the medical side, but that is up for individuals to find religious authorities that they trust and they find authoritative to take that conversation forward.
There's a very interesting question here. If everyone can just have a look, in case I misunderstand it. But it asks, if patients with conditions in the compendium choose to fast against medical advice and they deteriorate, are there any adaptations needed to, I think, for emergency treatment? I think they're talking about the first responders.
I'm not sure if I could answer that question slightly differently. And I want you to think about other patients who make unwise decisions. how, like, for example, someone who's a drug user who continues to inject drugs, someone who's an alcoholic who continues to drink alcohol. I'm not saying our patients who fast against medical advice are of a similar sort of nature in terms of their unwise choices, but it is still something that's against medical advice. And we use a harm reduction principle when it comes to those other patients that I mentioned. Sometimes I feel that, as Muslim practitioners, we sometimes don't quite know how to have that same harm reduction conversation with our patients, which is very much what the compendium is about, as to how do we manage that potential harm and try not make it a harm, but also be very clear as to what your medical guidance is and what you are medical legally bound by. In terms of the rest of the question, I might want to pass that back to the colleagues, since I didn't quite understand it myself.
I think it's acute, like first responders. This might be somebody working in an ambulance and they.
Okay, so I understand what that question means. So there'll be two scenarios. One is, for example, someone has become acutely unwell and someone has come to attend to them from an ambulance. The other might be they've been brought into a receiving unit or an A&E setting, emergency department setting, and they're fasting. It's likely if there's a first responder coming that the patient, obviously depends if they're unconscious or not. So the first responder will be duty bound to act in the best interest of the patient. What we would probably say is that it'd be too much to expect a first responder, unless they're in a Muslim country and they're clued up, to understand what may or may not cause a patient's fast to break. For example, if they're putting something in their mouth and cause them to swallow something, or putting a drip, and some people have different opinion in terms of a drip invalidating the fast. But what I would say is that clearly if they're unwell enough that they needed a first responder, they probably should be breaking the fast anyway, in which case that fast can be made up later. There would be no penalty because there'd be a legitimate reason for that fast to be broken. Likewise, for example, if a patient has been brought to an emergency department or is sick enough to be admitted to hospital, again, if they're in a fasting state, one should question what is the benefit to the patient in fasting. This is why sick day rules are important to be given. And I'll give you an example. When I had a patient who came into the acute receiving unit and they were actually undiagnosed hypoadrenalism from a pituitary tumor. I'd seen the blood results done by the GP, and I'd seen that their state, and I actually gave them a glass of water, and I actually asked them to break their fast because they needed treatment, and they had no issues because they understood what's wrong. So a lot of it will actually come back to actually understanding the patient's condition, understanding the fact that fasting in that circumstance may actually be harming them further. But again, this comes back to the understanding and education of the patient and also of the healthcare practitioner looking after them. There is no easy one answer that will fit what to do. I think the most important thing is that for sick day rule advice to be given to patients, and also general education to take place for the lay Muslim and the communities, to make them understand that if you are unwell, then it is there is no consequence of breaking the fast. In fact, it may actually be considered to be meritable and rewardable to break the fast, because what a person is doing is looking after their health, and the Quran is very clear in stipulating that Allah does not need a damage to ourselves or harm to ourselves. So again, it comes back to education when it comes to these situations.
Anyone want to add on? No. Okay. I think that was very good discussions. We're going to come towards the end of this event. Just as a reminder to those watching, we're going to have a QR code for you to register to get your certificates at the end, so don't leave just yet. But before we go, I'd like all three of the speakers to just give some closing remarks, and if you could maybe explain to us on the compendium if we would want to be involved, or on an international level. BIMA's done excellent work, and I think it's a good platform for others from other countries, Malaysia especially, since we are a majority Muslim country. Very proud of that. And we have to manage a lot of this kind of cases, and it's looking into evidence, which is very good as well. So maybe a few words.
We would strongly advise those individuals who are interested in Ramadan or from countries with significantly larger Muslim population to think about doing research studies or doing even audits of work to look at the impact of various outcomes in Ramadan from fasting, or equally if any interventions have been used, because this is where we need to generate our evidence. For example, if you were to look at the hypoadrenal section, we actually do have a study that was undertaken in North Africa, looking at the use of prednisolone instead of hydrocortisone when it comes to Ramadan fasting. And because we have that evidence, we actually were able to use that to shape the paper that we wrote, and also to provide patient advice. It's only one paper, but it shows you how much a good study with pragmatic advice can help us in terms of providing that guidance to healthcare practitioners and patients.
Okay, thank you very much, Dr. Nazim. Dr. Ahmad, maybe you want to give your...
Yeah, I would say my message generally, we're now sort of getting close to Ramadan in the next sort of 4 to 6 weeks, and preparation for your patients is really key. A lot of these issues do tend to come up in the days and the week running up to Ramadan, but particularly so my area in neurology, medication titration for patients with epilepsy or migraine or Parkinson's disease, these things take time, and if you're going to employ strategies such as trial fasting or looking at previous experience of fasting, these things all take time. So encourage your patients to engage with you in good time. Now thinking now about Ramadan, or next year, even 2 or 3 months in advance is really key. And in terms of involvement with the compendium, I think I would echo what Brother Nazim was saying, that the best thing that we can do, and particularly from areas of the world with large Muslim populations, is to encourage good quality research. This is a growing area, and having sort of trolled through the literature regarding this thus far, I would say diabetes is an area where mashallah things are fairly well developed. But outside of this, in a lot of other conditions, we don't have a lot of good quality evidence to take our practice forward. And because, as clinicians, we're so used to relying on evidence base to inform our decisions moving forward, then it's a real opportunity for countries with large Muslim populations to do good quality research in this area.
That's great. And Brother Saman?
Thank you. Just to echo what the other two have said, I think the preparation aspect is key to all of this, and that preparation also applies to things from a public health perspective, so not just from what happens leading into in Ramadan itself. So as I mentioned before, what levers do you have in your countries where you have got better relationships because of the numbers that you have, the Muslims that you have in your country? You're able to have your health system better designed for Muslims, but actually how well designed is it? Do you have smoking cessation programs that are tailored for Muslims in Ramadan? What do they look like? What is the evidence around that? Can you share that evidence with the rest of the world? Do you have weight management interventions, for example, in Ramadan that we can all learn from and we can benefit from? Going back to what Ahmad was saying in terms of involvement with the compendium, we have a lot of methodological expertise in the institutions that we're in, and involved in many other areas of our work, and we would love to bring that into Muslim majority countries where trial recruitment can take place, but doing it in a way that we can get it published in high quality journals. Alhamdulillah, we've shown that from the work that we've done, and this is just evidence synthesis. We're just laying ground zero, as it were. We want to sort of really build up, and the area that I think we need to build it up is actually what are the priorities for Muslims. And we had some wonderful discussion today, which I think teased out some of those issues around, how do you have that conversation with scholars? What does that sort of interface look like? Or things like multimorbidity, frailty, all these things. No one has actually done papers in this area as to what to do. And I think if we can have that data, pregnancy is another big one. Constantly breastfeeding, there's lots of areas where there's significant uncertainty and significant burden, therefore, that clinicians and patients carry, which I think with just a little bit of effort, a little bit of coordination, we can really give people more clarity around that. So I would welcome people getting in touch through BIMA, through us personally, through IMAM, through FEMA to try and create some form of international collaborative where we can look at not just Ramadan, but other Muslim health issues as well, especially with things like, genomic medicine coming in and things like mental health being a particular area of focus for Muslims, where we can, hopefully come together and look to bring more solutions.
That's wonderful. Alhamdulillah, and that's a great way of, signing off from this event. Lots and lots for us to do as Muslim practitioners, obviously, with more and more patients being more informed about this. Thank you. I would like to say Jazakallah khairan kathira to everyone that has attended today. I'd just like to update on the statistics. We have 140 watching on YouTube and around 25 on Facebook Live. So just to remind everyone who wasn't able to come in the first part, you can actually rewatch it if you just go to the YouTube, and you can rewatch it, because I'm getting some messages that some people have missed it, and I'm sure BIMA can help share the links as well, so they can have a look at this at the video again. So I think with that, I would like to congratulate all three speakers and thank you, and hope to be seeing you again soon for other events internationally. I think it's a very good platform, and as Muslims, we should be talking to people from all around the globe under whatever umbrella we are in. So thank you very much. I think we will end here. My screen should be able to give everyone a QR code of the link for attendance and also for certificate purposes. For Malaysians, you will be getting CPD points, but I'm aware that for international participants, we'll be giving a certificate, and you can use that to get your CPD points as well. So with that, I'm going to end here. After I end this, the QR code will come up. So Jazakallah khairan kathira. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam wa rahmatullah.